So hello and welcome to today's event, IPC in Urban Indian Behavioral Health Settings. I am your host, Sophie Chishti, and I am a Public Health Project Coordinator with the National Council of Urban Indian Health. Today's event is the second event in our NCUIH Project Firstline Community of Learning series titled Infection Prevention and Control, or IPC, for Distinctive Urban Indian Care Settings. Today's session will be recorded for educational and quality improvement purposes. We ask that you please turn on your video if you can, mute yourself when you are not speaking, and introduce yourself in the chat by providing your name, organization, and any tribal affiliation. For today's session, after this overview, we will move into knowledge sharing by Zachary Prasadi, an IPC activity with Zoe Harris, and a UIO spotlight by Veronica Whitehorse with the San Diego American Indian Health Center. After that, we will have an open floor discussion before we close today's event. Objectives for today's training include to improve UIO workers' knowledge and understanding of general IPC concepts and actions in the UIO setting, to improve UIO workers' awareness of IPC considerations related to behavioral health services and resources for UIOs, and to create space for the event attendees to share knowledge, challenges, successes, and resources related to IPC considerations and strategies in a behavioral health setting. To provide some background, the National Council of Urban Indian Health, also known as NCUIH, is a national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NCUIH is the only national representative of the 41 Title V Urban Indian Organizations, or UIOs, under the Indian Health Service and the Indian Healthcare Improvement Act. NCUIH strives to improve the health of the over 70% of the AIAN population that lives in urban areas, supported by quality healthcare centers. Before we begin today's event, we want to acknowledge that NCUIH's office in Washington, D.C. lies on the ancestral land of the Nacotchtank people, later known as the Anacostan people, ancestors of today's Piscataway people. DC is also home to a diverse Native community of tribal citizens who continue to act as stewards of this land. NCUIH is committed to honoring and supporting Indigenous communities in all that they do. At this moment, we ask you to take a brief pause to acknowledge the Indigenous land you are joining us from. We want to acknowledge that NCUIH is proud to partner with Project Firstline as supported through our cooperative agreement. The CDC is an agency within the Department of Health and Human Services, and the contents of this program do not necessarily represent the policies of CDC or HHS and should not be considered an endorsement by the federal government. Project Firstline is a national collaborative led by the CDC to provide infection control training and education to frontline workers, and NCUIH is one of more than 75 partners across the country who are working to provide innovative and accessible infection control education to help prevent infectious disease threats in healthcare. Now, for the knowledge sharing portion of the presentation, we are going to hear from Zachary Prasadi. Zachary is a public health associate at NCUIH and worked many years as a registered nurse in a pediatric emergency department that provided emergency behavioral and mental health services to his community. He also holds a master's degree in public health with a focus on health promotion. And now I'll hand the floor over to Zach.
Thank you, Sophie. Hello, everybody. Thanks for being here with us today. I'm very happy to be here with you to provide some context and some insight into infection prevention and control, or IPC, considerations for organizations that provide behavioral health services to their communities. I'm going to dive right in and start off by providing some background information. So what is behavioral health? Behavioral health is a broad term that's used to describe many different things. According to the American Medical Association, behavioral health generally refers to mental health and substance use disorders, life stressors and crises, and stress-related physical symptoms. Pretty general, right? So following that same logic, behavioral health services are those which are intended to address issues related to mental health and wellness, such as alcohol or drug use treatments, counseling services, services related to managing acute and chronic mental illnesses, and the list goes on. Behavioral health services are important now more than ever. We've all just lived through multiple years of a global pandemic, so many of us can personally attest to the mental stress that's put on us. For some hard data, according to the Substance Abuse and Mental Health Service Administration, or SAMHSA, nearly 1 in 5 US adults suffer from a mental illness of some kind. And the age group with the highest percentage of individuals with mental illness are 18 to 25-year-olds, with over a quarter of that population suffering a mental illness to some degree. It's also worth noting that this data is from 2017, over 5 years ago, and the data from that report demonstrated an upwards trend in the prevalence of mental health issues in the United States. Besides this, the CDC's Whiskers leading cause of death visualization tool shows that in 2020, the leading cause of death for persons aged 15 to 45 was unintentional injury. And within that umbrella term, poisoning related to exposure to narcotics or psychodysliptics, aka drug overdose, was at the top of the list for causes of death for all age groups between 15 and 44 years. If that data wasn't concerning enough, suicide is amongst the top 4 causes of death for people in the United States from the age groups 10 to 44 years old. And that's a lot to take in, but that goes to show that the work that you do day in and day out is so incredibly important. Another consideration about the importance of behavioral health services is that as Indigenous communities have known for thousands of years, people are multifaceted and that the mind, body, emotions, and spirit are all interconnected, and all of these aspects require support for a person to be healthy. Now, we saw on the previous slide the need, but now we're going to dive in a little bit more. And we know that this conversation is pertinent to UIOs because most, if not all UIOs, provide behavioral health services in some capacity. And this might look like individual counseling, psychiatry services, alcohol or drug treatments, youth groups, tobacco cessation programs, and many more services. We also know that there's a significant need for high quality behavioral health services specifically designed to meet the needs of Indigenous communities. Discussing health disparities, data from IHS shows that Native communities suffer from disproportionately higher rates of behavior-related morbidity and mortality than the rest of the US population. In recent years, American Indians and Alaska Natives had the highest rates of suicide of any minority group within the United States, experienced disproportionately high rates of substance use disorders, and deaths related to alcohol and drug overdoses. There are many interconnected factors contributing to the disproportionately poor health outcomes, but it's at least partially attributed to the effects of long-term and persistent colonization and systemic racism. And now we've discussed the challenges faced by Native communities, but we often brush over the strengths inherent to these communities. We've seen time and time again the resiliency of Indigenous people across the country. Furthermore, we know that whenever you have health services designed by Native people for Native people, that the health outcomes are better. When the patient and the health practitioner are in sync, there's a higher probability of positive health outcomes. Now we have a few different behavioral health initiatives and concepts that are useful in providing high quality and patient-centered care. I won't go into great detail here, but I'll give a brief description. Behavioral health equity, according to SAMHSA, describes advocating for the right to access high quality and affordable health services for all people, including racial and ethnic minorities, sexual and gender minorities, and people otherwise adversely affected by persistent poverty or inequality. Behavioral health integration, per the American Medical Association, is where healthcare workers from different specialties work in varying degrees of coordination or integration rather than in silos. And this ensures that patients' behavioral health needs are addressed, regardless of the primary complaint for which they're being treated in a healthcare facility. Integration may look like providing mental health screening with every visit and referring patients out to behavioral health services when necessary, or even having mental or behavioral health specialists on site to provide services. With behavioral health integration, we have the IPC consideration of providing different health services within the same facility. So it's important to take appropriate infection control precautions. One example of this, which I've seen, is a facility having 2 separate waiting areas, one for patients with symptoms that could be indicative of infectious illness, such as cough and fever, and one for patients without these symptoms. Maybe they're being seen for a non-emergent physical injury. And lastly, we have trauma-informed care. And this, according to SAMHSA, is when healthcare systems and providers take into consideration the patient's lived experiences in order to provide compassionate and effective treatments, which can increase patient engagement, increase treatment adherence, positive health outcomes, and even healthcare staff wellness. And now many UIOs provide traditional healing services such as sweat lodges, smudging, traditional medicines, talking or drumming circles, and storytelling. Existing literature shows promise in the use of traditional ceremonial practices to address substance use and other disorders amongst Native community members. Specifically in urban settings, traditional healing is tailored more to community needs, conditions, and mental health objectives in order to meet the needs of multi-tribal patient populations. Community members and service providers in an urban community have reported traditional healing can support physical, spiritual, and mental health, and can serve as a complement to European-based medicine. And with some traditional healing practices, there are risks for the transmission of infectious diseases with some of these activities due to close physical contact, sharing of healing tools, and the potential inhalation of droplets dispersed into the air. Furthermore, elevated body temperatures may react to certain infections, such as herpes simplex infections, or suppress immunity by reducing natural killer cells. We're at an interesting time in terms of incorporating traditional healing practices into modern medical facilities. And because of this fairly recent marriage of the two modalities, traditional healing and modern medicine, we see a need to apply IPC considerations to traditional practices. Medical organizations should work together with traditional healers to develop procedures that respect traditional practices while protecting community members. And this might look like individuals who utilize sweat lodges, bringing their own towels, using single-use disposable cups when drinking traditional medicines rather than sharing a drinking vessel, or utilizing single-use tips when smoking traditional herbs. Infection prevention and control is essential at protecting patients in every healthcare setting. Healthcare-associated infections are responsible for tens of thousands of deaths in the United States each year and cost tens of billions of dollars to the health system. And we hear these figures a lot, usually in the context of hospitals or other acute care settings, but they are applicable to facilities that provide behavioral health services. Furthermore, as we discussed previously, many urban Indian organizations offer a mix of medical and behavioral health services. Thus, it's important to understand infection risks and take measures to minimize the risks in every healthcare setting. Furthermore, specific to behavioral health settings, literature suggests that individuals with mental health needs are at an increased risk for developing infections due to poor health behaviors, diminished immune functioning, and negative disease outcomes. This data is a poignant call to action to do our best to protect our patients. But it's also important to remember that the health worker who's providing care to these patients is also a person who's important and loved by their families and communities. So we practice infection prevention and control strategies to protect ourselves and our loved ones also. Here we have a quick reminder about two key components in the spread of infection: reservoir and pathways. And now I know we've talked about this a lot during this Community of Learning series, but that's because it truly is vital to understand to interrupt the chain of infection. Reservoirs are where germs live, such as on your skin, under your nails, in your gut, in the respiratory system, and in the blood. And germs also live in the environment and can be found on both wet and dry surfaces, in dust and dirt, and on devices and supplies. Pathways describe ways in which germs spread from a reservoir to a new place to live. And this can happen through touch, like when a person touches a surface that has germs and then touches a portal of injury to their body, such as their eyes or other mucous membranes. And germs can also be dispersed into the air when a person coughs or sneezes. And these germs can be transmitted when another person breathes them in. Also, the skin naturally does an amazing job at keeping germs out of the body, but a cut or other break in the skin can act as a portal of entry where germs can bypass the body's natural defense. And per the CDC, standard precautions should be used for all patient care. It's based on a risk assessment and makes use of common sense practices and personal protective equipment that protects healthcare providers from infection and prevents the spread of infection from patient to patient. CDC's standard precautions provides guidance for several different situations. There's guidance for the use of hand washing with soap and water and cleaning hands with alcohol-based hand solutions. One specific behavioral health considerations related to hand cleaning is that facilities should take measures to protect suicidal patients from the consumption of alcohol-based hand sanitizers. All hand cleaning solutions should be under the control of healthcare personnel in settings with patients who are at risk for suicide. There's also guidance for the use of personal protective equipment, or PPE, such as using PPE when there's an expectation of possible exposure to infectious materials. And there's also current guidance on the CDC website, but the information is frequently reviewed and updated. So it's important to check the website regularly for the most up-to-date guidance. The CDC standard precaution guidance also addresses respiratory hygiene and cough etiquette, guidelines for environmental infection control and cleaning and sterilization. And you can also find guidelines for safe injection practices and sharp safety. It's worth reiterating that hand washing and environmental cleaning are two key elements in infection prevention and control. A few other considerations are the type of material that you're using. For example, it's recommended to use a non-porous material like a solid plastic clipboard rather than a wooden one, which can be cleaned and disinfected after each patient use. Also, use facility-approved hand lotions that don't degrade your gloves. And now we spoke a little bit about risk recognition already, but what is it? Risk recognition, related to infection prevention and control, describes seeing the potential for a problem to happen and then acting accordingly to minimize the risk of infection to spread. When we recognize germ reservoirs and pathways, which we discussed earlier, coupled with the implementation of standard precautions, we've already significantly reduced the risk of infection transmission. Regarding some specific IPC considerations relevant to behavioral health, the Association for Professionals in Infection Control and Epidemiology, or APIC, reminds us that in behavioral health settings, hand washing remains a key action in the prevention of the spread of infection. Even if surfaces don't appear visibly soiled, germs are present. And this is important considering that many UIOs provide group therapy and community wellness activities where there might be a large group of people potentially sharing supplies and equipment. Again, APIC reminds us, if you don't kill or wash these germs off your hands, they can get into your body when you eat or touch your eyes, nose, or mouth. You can also unknowingly move germs around so others get sick. Besides community events and group or individual therapies, behavioral health services also include services provided to individuals who may have a higher risk of being exposed to infectious diseases. Data shows that alcohol and drug use may lower inhibitions and increase a person's involvement in sexual activities that may have a higher risk for infection transmission. HIV and viral hepatitis can be transmitted through unprotected sexual activity. Besides this, people who inject drugs per the World Health Organization are at an increased risk of HIV, tuberculosis, and viral hepatitis. Also, people with inadequate housing may have wounds that they can't properly take care of and may be at risk for infection. Now, this data is not intended to make a healthcare staff afraid to treat a patient who may have engaged in any type of behavior or live in a particular situation. In fact, it's vitally important to not perpetuate harmful stigmas. What is important is to use personal protective equipment appropriately, have infection prevention policies and protocols in place, along with having protocols related to healthcare staff exposures, such as through an accidental needle stick. The CDC's Project Firstline website is a great place to find infection prevention and control resources geared towards frontline healthcare workers, and we'll put a link in the chat for you to follow. Here it shows that accidental needle sticks are a common injury for healthcare workers in the United States and represent a risk for disease transmission. With needle stick injuries, there is an infection transmission risk for diseases such as HIV and hepatitis. The CDC provides information and resources on how to mitigate the risk of accidental needle sticks, including using needles with appropriate safety features, avoiding recapping needles when possible, and disposing of sharps appropriately. The CDC also provides guidance on what to do in the event of a needle stick injury or needle-related exposure, and that is to immediately wash the needle stick site with soap and water, flush any splashes to the nose or eyes with water or sterile irrigants, report the incident to your supervisor, and then follow post-exposure protocols. It's also important to reiterate the importance of reporting and following appropriate protocols in the event of a needle stick injury. In a study from the Journal of the Royal Society of Medicine, researchers received an anonymous survey from 279 doctors and nurses. 74 of the healthcare workers surveyed reported having sustained a needle stick injury in their career, but only 51 had reported all needle stick injuries. This was a small local survey, but it's congruent with the past studies demonstrating a troubling underestimate and underreporting of needle stick injuries in healthcare workers. The procedures related to needle sticks are there to keep the healthcare workers safe, not to punish or shame them. And here, as we mentioned before, it's important to avoid perpetuating stigma for individuals with behavioral health needs. There are three main types of stigma, including public stigma, self-stigma, and institutional stigma. Furthermore, stigma has many harmful effects, such as reluctance in seeking help or treatment, bullying, harassment, physical violence, or even discrimination. The Mayo Clinic describes ways that patients may be able to deal with stigma, and that includes seeking community support, joining a support group, avoiding isolation, and seeking appropriate treatment. Stigma associated with infectious disease can be a barrier to adopting healthy behaviors, leading to more severe health problems, ongoing disease transmission, and difficulty controlling infectious disease outbreaks. The National Alliance on Mental Illness also offers some suggestions about what we can do as individuals to help reduce stigma of mental illness. We can talk openly about mental health, educate yourself and others, be conscious of the language that we use, show compassion, be honest about treatment and normalize mental health treatment. Let institutions know when they're using stigmatizing language and choose empowerment over shame. Now I'm going to talk a little bit about burnout and compassion fatigue. The link between burnout and compassion fatigue and their effects on infection prevention and control practices is not clear. Burnout, as described by the US Surgeon General, is an occupational syndrome characterized by a high degree of emotional exhaustion and depersonalization and a low sense of personal accomplishment at work. People in any profession can experience burnout, yet it's especially worrisome amongst health workers given the potential impact on our healthcare system. Regarding compassion fatigue, caregivers can become so over-empathetic that they find themselves growing numb to their patients' suffering. Studies show that as the ability to effectively sympathize, empathize, and to engage in a caring way with our patients declines, the quality of patient and client care will also decline, leading to less than optimal care and outcomes. A cross-sectional study conducted in 2022 amongst healthcare workers caring for patients suspected of having COVID-19 during the height of the pandemic in Tunisia described how healthcare workers are highly vulnerable to compassion fatigue, which not only leads to decreased mental and physical health, but also to a deterioration in the safety of care delivered. The study goes on to propose that the ongoing COVID-19 pandemic is expected to have significant psychological impacts on healthcare workers, mainly manifested in anxiety disorders, burnout, and secondary traumatic stress. Indeed, compassion fatigue can have severe repercussions for both healthcare workers and patients. Our team presented a community learning event exploring aspects on burnout and IPC earlier this year, and you can view the recording on our YouTube channel. And furthermore, on a previous NCUIH Native Healthcast episode, Dr. Donald Warren discussed how chronic stress can reduce the body's ability to effectively fight off infections, making a behavioral health ailment directly related to infection prevention and control considerations. The podcast can be found on multiple streaming services. This is a complex topic that merits further discussion and research. However, we see that at least in some capacity, there is a relationship between compassion fatigue, burnout, anxiety, and infection prevention and control considerations. Therefore, we must prioritize actions that create safe and supportive environments for healthcare workers. There are other strategies that can be used and implemented in facilities that provide behavioral health services, which may decrease the risk of infection transmission. A pre-screening phone call that is conducted prior to a patient arriving to the facility to assess for signs and symptoms of possibly infectious illnesses, even if they're being seen for a behavioral health need, may be a useful tool. Symptoms may include cough, fever, or runny nose. Having masks and other PPE readily available for the staff and for the patient is important. Another strategy is to consider using telehealth services when appropriate. This is an effective method at eliminating the risk of infection transmission, but comes with some drawbacks. The patient and provider should work together to see if this is an appropriate method to meet the patient's individual health needs. Regarding de-escalation techniques, there's little research into the relationship between patients in mental health crises and infection transmission. However, a patient in a mental health crisis who engages in aggressive behavior may create a situation where there's an increased risk for infection transmission. This might happen if secretions from the patient's mouth come into contact with a nurse's eyes or other mucous membranes, accidentally or through spitting, scratching that breaks the skin, the body's natural defense barrier, or coming into contact with a patient's bodily fluids without appropriate PPE. All of these are situations where there is a risk for infection transmission. Crisis intervention and de-escalation techniques related to behavioral health are verbal and body language strategies implemented to de-escalate individuals out of an agitated state. It's important to note that patients in mental health crises are generally not dangerous and, in fact, are oftentimes the victims of violence rather than perpetrators. However, it is important to prevent situations where there is a potential for increased risk of infection transmission before it happens in the first place, and de-escalation training may help with that. The American Psychiatric Association Task Force on Psychiatric Emergency Services has recommended that staff receive annual training on managing behavioral emergencies and that all persons who work with agitated patients should receive training in de-escalation techniques. And finally, here we have some further resources related to behavioral health for patients and for healthcare workers. Each circle is hyperlinked that you can follow for more information whenever you receive the presentation materials. I want to thank you all for your time and for everything that you do to serve your communities. Thank you.
Thank you, Zach. We'll have time for questions on that knowledge sharing portion during the open floor discussion a little bit later in today's event. So now I'm going to turn it over to Zoe Harris to lead an activity. Zoe Harris is a public health associate at NCUIH and a community health sciences PhD student at the UIC School of Public Health. Zoe is a citizen of the Mashpee Wampanoag tribe and has worked with her own tribal community as well as urban Native populations in Boston and Chicago on topics of education, health promotion, and language preservation, specifically among youth populations. So I'll hand it over to you now, Zoe.
Thank you so much, Sophie. So for our activity today, we'll be taking some of the knowledge that we've learned today in addition to other IPC practices and taking the application one step further. All UIOs must go through review by the Indian Health Services, IHS, and that's within their Office of Urban Indian Health Programs, UIHP. And many UIOs seek to conduct further assessments, whether that is for self-improvement, for example, conducting an ICAR, or to earn accreditation through an organization like IIIHC or CARF. So this activity will go through a scenario step by step and apply them to different criteria from the CDC ICAR, IIIHC, and UIHP. As we go through a scenario, we encourage you to think about your own organization, your policies, your procedures. So feel free to add your own thoughts and questions as we go. And please note that this activity is meant to help UIO staff understand why policy and procedures are important for those everyday tasks. But adapting this example in your own workplace doesn't guarantee you'll meet the requirements of the named entities or other evaluating organizations. The three tools that we'll be using today are guidelines from the Accreditation Association for Ambulatory Healthcare, IIIHC, the CDC Infection Control Assessment and Response Tool, and the IHS UIHP Manual. And further descriptions of these tools are on the slide, and we encourage you to read more about them. The ICAR tool in particular is a resource that's available for institutions for self-assessing various infection prevention and control topics such as hand hygiene, environmental services, point-of-care blood testing, and wound care. These self-assessments do not take the place of assessments from accrediting bodies, but they can serve as a useful tool to identify potential gaps in infection prevention and control policies, procedures, and protocols. This is our scenario, so I will read through it pretty quickly and then we'll go through it step by step. But a behavioral health worker, or BHW, is wrapping up a day of meetings, case management, and behavioral health visits, and they have health education bingo in the evening. So they're calling patients to see if they're still attending and asking how they're feeling for the day. One of the elders says they're not feeling well, and the behavioral health worker suggests that they stay home for the night and offer an appointment at the clinic the next day. The elder agrees, and they make an appointment for the next day. And the behavioral health worker makes sure to leave a note in their electronic health record about the symptoms the elder described. After finishing the call, the behavioral health worker goes to set up the space for the evening event. All the tables and chairs are cleaned and disinfected. The iPad for sign-in is cleaned as well. And the behavioral health worker also wipes down all the bingo cards and markers as they lay them out on the tables. They also make sure that the air filters in the room are all on and move a box of swag away from a vent. With some time to spare, they eat a snack at one of the tables they just cleaned before people start to arrive. Suddenly, someone walks in and they brush the crumbs off the table, and both the behavioral health worker and the patient use alcohol-based hand sanitizer before greeting each other. At the conclusion of the event, the BHW cleans and disinfects everything again before closing up and going home for the evening. So now we'll begin. For each of the tools, we'll show the criteria as well as where it can be found in their respective tool. So the first part of our scenario is a behavioral health worker is wrapping up a day of meetings, case management, and behavioral health visits. There's health education bingo in the evening, so they're calling patients to see if they will be attending and how they're feeling. So starting with IIIHC and the section on IPC and safety, one of the criteria is that there is a written infection prevention and control program that describes how infections and communicable diseases are prevented, identified, and managed. In this case, the practice is to call community members in order to prevent the spread of the disease at the bingo event. Within the ICAR, this can specifically be applied to job-specific education and training on IPC. As a UIO worker, the BHW has their own training that can prevent the spread of disease, which comes in the form of screening community members for symptoms. And then for OUIHP, a UIO must have a process to identify and address potential infection risks based on factors as geographic location and services provided. So again, the behavioral health worker is making calls, but they might ask about specific symptoms depending on where they live. So for example, if there's a flu outbreak in the community, they may also specifically ask about those symptoms. Next, we go into one of the elders say they're not feeling well, so the behavioral health worker suggests that they stay home for the evening and offers to set up an appointment with the clinic for the next day. The elder agrees that they should stay home and agrees to come in the next day. The behavioral health worker makes an appointment and leaves a note in the EHR about the symptoms that the elder described. IIIHC states safeguards are in place to protect patients and others from cross-infection. Calling ahead of time helps to protect other community members from possible cross-infection. In addition, by booking an appointment, it can help with the treatment of whatever may be going on with the elder. And then finally, by including symptoms in the EHR the next day, any healthcare worker will be more prepared to take appropriate precautions. And this same logic can be applied to OUIHP. For the ICAR, using the EHR can help with auditing, as there will be a record of precautions that were being taken to prevent potential infection via the phone call and during the appointment the next day. After finishing the calls, the behavioral health worker goes to set up the space for the evening event. All the tables and chairs are cleaned and disinfected prior to the patients arriving. The iPad that is used for sign-in is cleaned and disinfected as well, and they wipe down all the bingo cards and markers as they lay them out on the table. The two IIIHC criteria we apply here are written policies address the cleaning of patient treatment and care areas, and policies address cleaning before use. In this case, the policy would be around cleaning of the space before it's used, and this is the tables, the chairs, the iPad, and the bingo materials. The ICAR covers policies around surfaces that should be cleaned routinely, and specifically how often non-critical patient equipment is cleaned and disinfected. For the scenario, the BHW is cleaning all these items prior to use, and the iPad will be cleaned in between each person as well. And similarly, for OUIHP, they discuss how cleaning of care areas should occur before use. Next, they also check that all the air filters in the room are on and moves a box of new UIO swag from in front of a vent. And this is in reference to ventilation. So IIIHC and OUIHP both mention how ventilation should be adequate and suitable for patient services. The ICAR does not specifically have criteria, but it does mention that facility ventilation systems are part of a demonstrated commitment to preventing the spread of infectious diseases. With some time to spare, the BHW eats a snack at one of the tables they just cleaned before people start to arrive. Suddenly, someone walks in and the BHW brushes the crumbs off the table. They both use alcohol-based hand sanitizer before greeting each other. So there's a lot going on, but we're going to focus on hand hygiene here. IIHC and OUIHP both state that WHO, CDC, or other nationally recognized guidelines for hand hygiene should be used. And IIHC adds that policies on how to use the products should be included, while OUIHP asks for steps on education, measuring compliance, and providing continuing education. The ICAR talks specifically about how when healthcare workers and patients should clean their hands. And in this scenario, the behavioral health worker might need some continued education because it's not clear if they wash their hands prior to eating. However, prior to greeting each other, both the patient and the behavioral health worker take the time to clean their hands with hand sanitizer. So creating a culture around IPC can be really difficult, but easy things like using hand sanitizer can go a long way. At the conclusion of the bingo night, the behavioral health worker cleans and disinfects again and closing everything up before going home. You might notice from looking at the screen that these are all the same criteria from the part of the scenario on cleaning and disinfecting before the event. And this is the same criteria, but just from a different lens. And now we're cleaning after use and as terminal cleaning at the end of the day. And this is just one example of how multiple IPC practices can contribute to the single aspect of an IPC program. And that brings us to the end of our activity on IPC in practice. We hope that you enjoyed this activity and were able to reflect on the everyday activities in your life and how they're relevant to these tools and vice versa. As a reminder, if your UIO would like to request technical assistance from the IPC team, you can fill out the form on the NCUIH website or email us directly at ipc@ncui.org.
Thank you for leading that wonderful activity, Zoe. Now we will move into our UIO spotlight and have the pleasure of hearing from Veronica Whitehorse from the San Diego American Indian Health Center. The San Diego American Indian Health Center, a 501c3 nonprofit organization, is a patient-centered health home that provides comprehensive medical, dental, behavioral health, and community wellness services that are available to all San Diegans. So Veronica, or Ronnie, is the manager for disease control and prevention at the San Diego American Indian Health Center. She has been at the San Diego American Indian Health Center for 18 years. Ronnie was born at Fort Defiance, Arizona, and her family soon afterwards relocated to Los Angeles. She received her BSM degree at San Diego State University. As the manager of disease control and prevention at SDAIHC, Ronnie handles diabetes education, women's health, case manages infection control, and is an all-around nurse. She is a member of the Sigma Theta Tau International Honor Society of Nursing, and in her free time enjoys sewing. And now I'll hand it over to you, Ronnie. Thank you.
Okay, well, thank you from San Diego. We're located about a mile above or north of downtown San Diego, and we are truly in an urban setting. So if you could go to the next slide. We'd also like to say that we acknowledge the Kumeyaay and their land and their traditions while we are here in San Diego. Thank you. When COVID-19 came, of course, we had to endure the lockdown, which started on March 15th of 2020. And we had to learn how to do telehealth visits from home. Most of the clinic staff here were placed on, I don't know what we called it, but anyway, they all worked from home, especially the behavioral health people. And groups that we offered were offered in Zoom format only. So one of our challenges were to try to work with clients because they had various ability to be able to connect to the clinic. Some had, no phones, some had limited access to any kind of communication. And things like the furniture in the In the treatment areas for behavioral health, which were all nice and decorated and nice woven rugs and cloth furniture, had to be replaced, and we ended up with vinyl and hardwood floors. Next slide. So we continue with that until the end of the emergency use authorization, which was May 11th, 2023. And we started opening visits to the clinic by pre-screening our patients for fever, cough, headache, and other symptoms. And if they were positive for any of these symptoms, then we rescheduled the clients to a telehealth visit. Initially, when they came to the clinic, we required that clients show proof of all their COVID immunizations before an in-clinic visit was scheduled, but now it's no longer required. So they could continue to use telehealth or come to the clinic at their appointment with or without a mask. Masks are provided if they desired, they're recommended, but not required. We also encourage hand washing, and hand sanitizer is available in each of the offices. Cavi wipes are provided in each of the offices for the furniture and surfaces for the wipe down before and after the visits. Each of the offices were equipped with a HEPA air filter. And at this point in time, 75% of our continue as telehealth visits. And group participants are invited to either participate in person or via Zoom now. Okay, next slide. So one of the things that happened as a result of our opening back up after May was that we increased our demand for behavioral health services, of course, went up quite a bit. And we found we needed to add more services in order to properly treat our patients, such as vital signs, point of care drug screens, and any other lab tests that we required, like lithium levels and other kind of medication levels that were important to help our providers treat our patients. So we added Kim as part of our services, and she does all the behavioral health medical assisting and receptionist duties for that part of the clinic. Okay, thank you. Next slide. Okay, that concludes my presentation. If you have any questions, and I thank you all for participating with us today.
Thank you for that great presentation, Ronnie. If anyone else is interested in presenting during the UIO Spotlight at these events, you can follow the link to the form in the chat to enter to participate. So now we will open the floor for any final comments or questions. Please feel free to share by unmuting yourself or by typing in the chat. And I see a question in the chat.
So, yeah,
oh, go ahead.
I see the question. So can you elaborate a little bit on what culture of care is for? I'm thinking that you're talking about the Zoom meeting or the group meetings where we do have, those are a little tricky to regulate, because as in the presentation that Zoe presented to us, or Zach, I'm not quite sure which, but getting people to adhere to infection control protocols while you're participating in something like a talking circle or a white bison event is tricky. You're trying to make sure that we do have hand sanitizer and encourage washing of hands but we try to make sure that, you know, everybody is comfortable with the cultural aspect of the event too.
Thank you for answering that, Ronnie. Does anyone else have any questions or comments?
There was a question from Molly about the response from patients and staff and how they had changed during and post emergency use authorization. I assume for Ronnie.
So for those who may not have heard, so there's a question in the chat. What was the response for patients and staff about the changes that were being made during and post emergency use authorization? I think that's probably a question for Ronnie, if you'd like to answer that.
Okay, it was challenging because, you know, a lot of our people like to gather, and to stop that and adhere to the COVID guidelines was very, very challenging. We did have a lot of, you know, pushback per se, not pushback in the sense that they didn't respect what we were trying to do, but it was a loss. Everybody felt that, the loss of being able to gather and being able to see each other and express their emotions and their journeys. So there was some issues regarding that too. Did you want to ask me something specific, or but that was mainly hard to deal with. You know, we have an annual event, we have an annual powwow, and there were no powwows. There were no any other kind of events that we could have at the clinic as a result of this.
Here's another question that's popped up in the chat. So what has your IPC staff training looks like, and how frequently do you do refresher trainings?
We do some online, so we have a lot of our training because of the nature of our business, and all of us have different types of scheduling and needs. We, of course, have patient care coming first, but so our administration has devised many ways to bring the training to you or to the employee as like online training, and we get we check in and we go through the training, and this happens annually. And then as needed, you know, if new protocols come up, for instance, when the COVID mandates stopped, then we go back and through and review, and constantly, even now, the COVID-19 quarantines continue to change, and the vaccine requirements continue to change. And I believe the last I heard was that there may be a new vaccine coming out sometime in September. So we've tried to keep up on everything and make sure that everybody here is educated. And, as most of you all know, that COVID was it was a challenge. Everything was changing almost weekly. So, yeah.
Thank you for sharing that, Ronnie. If there are any other questions or comments, please feel free to unmute yourself or share them in the chat. We also welcome anyone else from any other UIOs to feel free to share their experiences with infection prevention and control and behavioral health if you'd like to. All right, if there are no other questions or comments, I think we can move into the closing of today's event. So before we close today's event, we'd like to remind you that NCUIH has an IPC Assistance Center that you can join to access and share resources, interact with other UIOs, and more. You can also visit NCUIH's website, email the IPC team, and listen to the NCUIH Native Healthcast podcast. And these links will also be shared in the chat. We also have 4 community of learning events coming up later this year that we hope you will attend. The next session will be on September 7th. NCUIH also has additional events coming up, such as those you see here. Finally, you can scan the QR code on the screen or use the link that's shared in the chat to respond to a survey on today's event. And after submitting your NCUIH survey, you will also have the opportunity to enter a raffle to win a prize from NCUIH. And all of this information will also be shared via email with all of you. Thank you all for attending today's event, and I hope you all have a wonderful rest of your day. Thank you, everyone.